You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best, no matter what your hormones are doing. This show is a production of Live Feisty Media. Hello, strong, feisty women. So I have one of those deep dive episodes on tap for you, so buckle up. I have done a few shows on breast health and menopause. Most recently, I had on the wonderful Dr. Amy Commander, who convinced me to go get my mammogram after many years of not making that appointment, and now I've been doing it on the regular. Thank you, Amy. I also had on Dr. Corinne Menn, who is a young breast cancer survivor herself and is really rewriting the script on hormones and breast cancer. I had her on twice, as a matter of fact. I invite you to check out all of those shows if you're interested in this topic. But I haven't devoted a whole show to hormone therapy and breast cancer risk specifically. So it was high time to do that. And boy, this one did not disappoint. I had the opportunity to sit down with Dr. Mindy Goldman, who is a clinical professor in the Department of OBGYN at the University of California, San Francisco, where she is also the director of the Gynecology Center for Cancer Survivors and At-Risk Women. So she is deeply connected to this topic, including how hormone therapy impacts breast health, what we know about breast cancer risk and hormones, and really what everyone who is concerned about this topic should know. And as you might imagine, it's complex because hormone therapy, as I say all the time and has come up on this show a million times over the past 4 years, is not one thing. And the forms and formulations and combinations really, really matter. And breast cancer is not one thing either. It is many different types of disease. But more women can safely use hormone therapy than we've traditionally believed. And it's important to find a doctor who is well versed in the literature and who understands menopause medicine. And I'll be clear right up front that Dr. Goldman is also Midi's chief clinical officer. And Midi, as you know, is a sponsor of this podcast as of the past few months. That could certainly be looked at as a conflict, and I thought long and hard about it. And in the end, her credentials made her a very clear choice to be the one to do this show with. Dr. Goldman is a nationally recognized expert in the management of women's health issues, including menopause for women with cancer or at high risk. She has helped author guidelines in the area of managing menopause for women with cancer or at high risk for cancer for the American College of Obstetrics and Gynecology, and she is on the survivorship panel for the National Comprehensive Cancer Network, where she is the chair of the menopause panel, providing guidelines for practicing oncologists. I will put a link to her bio in the show notes so you can check out her impressive resume for yourself. I hope you enjoy this one as much as I did. She really brought it with a lot of thoughtful, detailed, nuanced information, and I always very much appreciate that. Okay, before we get to it, give us a follow at Feisty Menopause on Instagram and Facebook. Come join our private and ever-growing Hit Play Not Pause Facebook group. Head on over to feistymenopause.com and check out our Level Up membership and our Navigate Menopause course and my 100% free Feisty 40 Plus newsletter. Thanks, as always, before we get to it, for the continued great ratings and reviews. I really appreciate them. And very quick thanks to Previnex for their longtime support of all things Feisty Menopause. Their muscle and joint health products have been a smashing success for so many of you and for me. And I'm just stoked that we can help so many women keep kicking ass pain-free because of them. So thanks, Previnex. I really appreciate it. All right. Enough of me. Let's have a few words about our awesome sponsors and get on with it. Okay, Dr. Goldman, as I was saying before I hit record, I'm actually really overdue for this conversation. The topic of breast cancer and hormone therapy has such a long, confusing history, and I don't think it's gotten any clearer. In fact, I think the water has gotten so much muddier. So I'm very happy that we can have this conversation. So thank you for joining us.
Well, I'm really excited to be here. So thank you for wanting to have this conversation.
So, to start, I would actually like to set the stage and help women understand the relationship between estrogen and breast cancer, as well as progesterone and or progestins with breast cancer, because there is so much confusion to this day, even at that very basic level. And when I actually did a little Googling and looked up estrogen and cancer, the first thing I got was a citation from the NCI labeling estrogens as human carcinogens. Yet the WHI and other research has shown protective effects for women on estrogen-only therapy. For women who don't have a uterus, hormone therapy has been deemed largely safe. So can you please just help us understand the groundwork there?
Sure. So carcinogens just means that something, whether that's a hormone, a drug, or something, has the ability to impact DNA within a cell. And DNA helps to control cellular growth, proliferation, cellular death. So estrogens, we know, can impact cellular regulation. So in that way, it is possible that hormones, as well as many, many other drugs, could have the potential to be carcinogenic or affect cancer. But we know that environments, genetics, many, many other things impacts how tissue responds to hormones and other drugs. So just because something impacts DNA and cellular growth does not mean that it is necessarily going to cause cancer.
Okay.
And that's where studies come in, right? That's where you have well-designed studies to look at something like, in this case, estrogen or progesterones to see, does it impact a clinical outcome? So what happens on a molecular level doesn't mean on a population level that that's going to cause cancer. Does that make sense? Because I think it's a confusing kind of misnomer.
Yeah, totally. And then, talking about progesterone specifically, like that comes up a lot at the society meetings, right? Like, oh, it's the progesterone that seems to be the problem, as you'll hear about it. And, the WHI and other research has shown like that progesterone appears to be linked to higher breast cancer risks, the longer exposure. What do we know there? And then what do we know about the difference between micronized progesterone and progestin?
Okay, so in order to answer that question, are you okay if we kind of take a step back and talk about the WHI and
Sure.
estrogen, progesterone, or progestins in general? So if you go back to the early 1990s, women were routinely given hormones. And the primary reason for that was that there was a thought that hormones prevented heart disease, and heart disease is the #1 cause of death. And then in the late 1990s were the first well-designed studies where they actually looked at women who were really high risk. They had already had a cardiac event to see if they gave them hormones, did it modify the risk of a secondary cardiac event? And lo and behold, it did not. And
Mhm.
people thought, well, that's sort of interesting, but that's not really who you want to look at. You want to look at healthy menopausal women and see if you give them hormones, does it modify the risk of getting a cardiac event? And that was the design of the WHI. And it was, to date, even the largest NIH sponsored trial, multiple different studies within that study. But the hormone study was designed to see whether the use of hormones prevented the #1 killer of women, heart disease. It was not designed to see, do hormones help treat symptoms? It was all designed to look at heart disease. And they looked at two groups of women, women who had a uterus and women who did not. We have known since the 1980s that if you have a uterus and you take hormone therapy, that you need progesterone, some form of progesterone to protect against uterine cancer, versus if you have no uterus, estrogen alone. So estrogen tends to be the component that makes you feel better. You need progesterone for uterine protection. So two
Yep.
large groups, estrogen with progesterone versus placebo, and estrogen alone versus placebo. They used a specific type of hormones. They used an oral form of what was called the conjugated estrogen, and they used an oral form of the same conjugated estrogen with a synthetic form of progesterone, or a synthetic form of progestin.
Mhm.
Okay, progesterone is a natural form of a progestin. The reason they did was that was the most commonly prescribed formulation of hormones in those days, as well as the company that made those hormones helped to underwrite the study because they anticipated getting a cardiac benefit. The
Okay.
study was scheduled to go to multi-center trial, places all over the US, more than 16,000 women in the arms. Like, this was a really well-designed study and the largest study, right, to look at this question. And there was the study was scheduled to go till the mid 2000s, and there was a lot of bad press in 2002 when the estrogen progestin arm of the study, called Prempro, was
Yep.
stopped short with the finding it didn't protect against heart disease and it surpassed the threshold for breast cancer. Media totally takes off with those results. All women start calling gynecologists in those days and saying, get me off hormones, they must cause breast cancer. We can talk about how the media totally overblew the results and there's been a lot of misinterpretation, but the Premarin, or estrogen only arm of that study, did not find that.
Yep.
It continued and stopped 1 year earlier than planned, not because of breast cancer. And in fact, at that time, they found a lower risk of breast cancer,
Yep.
but that never got publicity. But
Yep.
it was stopped 1 year earlier because it did not protect against heart disease and it surpassed the threshold for stroke.
Gotcha.
Now, those women have been followed out to current day. We also have had other studies looking at other types of hormones different than the types that were studied in the WHI, and some of the things that we know about now. One is that study was designed to look at heart disease, so they chose to look at an older age population.
Right.
The average age was 63, but the average age of menopause is 51. And most people coming in to ask about using hormones are in their 40s and 50s and not in their 60s.
Yep.
And in the group of women in the WHI who were within 10 years of menopause or under age 60, the findings were very different. Hormones did prevent against heart disease, and some parts, the estrogen only, had shown a lower risk of dying of anything. And that has helped lead to what's called the timing hypothesis, which says the risks and benefits of hormones differ depending on the age of the patient and years since menopause. And if you start hormones early, the benefits tend to outweigh the risks when it comes to heart disease. And the theory is if you start someone early, they don't have plaques in their coronary vessels, which is what leads to heart disease. And we know that estrogen dilates coronary vessels, it makes them less sticky, so platelets can't form, and all of the factors that lead to plaques. And so if you start someone early, you prevent that from forming. But if you wait till someone's already been menopausal for 10 years, they probably already have those plaques in those vessels. And so making those changes is not going to impact cardiovascular risk. So that's one thing we have learned since then. There have also been other studies that have looked at different types of estrogen. And we know that oral estrogens have a 4 to 5-fold higher risk of blood clots. Blood clots also means increased risk of strokes. And we now have lots and lots of data that has looked at non-oral formulations like patches and gels, and those are not thought to increase the risk of stroke
Mhm.
or blood clots, which means those can be safely used in people who are at higher risk. So we know that hormones are not hormones are not hormones. There have also been studies that have looked at the Women's Health Initiative participants looking specifically at breast cancer outcomes, which I know gets us back to
Yep.
what you asked me in the first place. So this was published in 2020 in JAMA, one of the premier medical
Yep.
journals that looked at 18-year follow-up at that point from the WHI participants. And 18 years later, what they found was the group that got estrogen with the synthetic progestin did have a higher risk of getting breast cancer, statistically higher risk of getting breast cancer compared to the placebo group, no difference in dying of breast cancer.
Mm-hmm.
The group that got estrogen only versus placebo, statistically lower risk of getting breast cancer and statistically lower risk of dying of breast cancer. So that suggested what other studies have shown, that it is more the progestin component that may have negative effects on the breast. Now, the WHI has been called into question because it turns out the breast cancer risk was only seen in a small subgroup, which is people that had previously used hormones before entering the study. And in that subgroup, also the placebo group had a lower than expected rate of breast cancer, which magnified the risk that they saw. So there are some questions about that. But despite that, there have been other studies that have been done throughout the world that have all suggested there is a higher risk of breast cancer with combination estrogen and progestins and lower risks with estrogen alone.
Mm-hmm.
So then that leads to the question, well, if it's the progestin component, are progestins all the same?
Right.
So what you asked me before, is micronized or natural progestin the same? And they are not all the same. So in the Women's Health Initiative, they studied a synthetic form of progestin called medroxyprogesterone acetate. And we know, for example, that that form binds to receptors very tightly, and it can have different effects in different tissue. So for example, if someone has irregular bleeding, we oftentimes will use progestins to help control that. And medroxyprogesterone acetate is one of the best forms of progestin to help control irregular bleeding. But we know that that can affect the breast differently than natural forms of progesterone. And there have been studies that have looked at whether micronized progestin, which is micronized progesterone, which is a natural bioidentical form of progesterone. Bioidentical just means similar to what our body produces, whether that increases breast risk. And there is a suggestion, we don't have clear randomized controlled trial data, but there's a suggestion that it does not. So the types of hormones we use nowadays are very different than what was studied in the WHI. There still is a role for the types of hormones that were used in the WHI. Like I said, if you have irregular bleeding, that's a type of progestin that I would recommend. But I think it highlights, this is complicated. And I think there are a lot of people, unfortunately, that were really biased by what the press did from publication of the WHI, and there was a lot of misleading information. It's affected both the public's perception of, do hormones influence the risk? Do they cause breast cancer? But it's also influenced the medical profession. And anyone who had trained in the past 20 plus years since the WHI came out has not gotten adequate training in menopause medicine and in the true benefits or risks associated with HRT.
Yeah, there's a lot to, to dive into there. I am curious as you were talking, one of the discussions that came up at, I think it was last year's Menopause Society meeting, was about Duovy. Is that how you pronounce it? The conjugated estrogen and bazodoxifene, which, they talked a lot about because there's this press, this almost full court press to be like, okay, if it is maybe the progestins, maybe we try to find some way to like get those benefits of the estrogen without any, potential risk. But they're also using the conjugated estrogen. So I'm curious what your thoughts are on that specific medication or therapy.
Yeah, that I love that question, because what I was at the Menopause Society
Okay.
meetings last year, and someone raised the question, why did they choose to study the conjugated estrogen
Yeah.
when they made Duovy? So Duovy actually first came on the market, I think, in 2012. I may be mistaken, but somewhere around there. It then went off the market in 2020 because of packaging
Right.
issues,
Right.
and it came back on the market last year in 2023. When Duovy was made, they felt like they had the best data on conjugated oral equine estrogen, and that's why they chose to put it in there. Now, I originally thought, well, they should have used bioidentical estradiol, which is what we're using in patches, and we know that that's safer from a clotting perspective, like I talked about, and you avoid first pass metabolism through the liver, and so there tends to minimize side effects. Like, why didn't they use that? Well, there was an interesting article that came out by Jim Simon and Barbara Levy this past April. That's called A Contemporary View of Hormone Therapy. And one of the take-home points of that article was hormones are not hormones are not hormones. And once we get to the point where people start understanding menopausal medicine and really start looking at what are the benefits and should we be giving HRT to most women when they are perimenopausal and menopausal, the next step is we need to get to personalized menopausal medicine and realize that different hormones have different effects on tissue. And
Definitely.
one of the arguments they made is if you want breast cancer prevention, it is probably that oral conjugated
Yeah,
estrogen that has the best prevention of breast cancer compared to the natural bioidentical estradiol. So, but that's why they chose that drug. And then it's a really interesting thing that they combined it with what's called a SERM. So a SERM is a selective estrogen receptor modulator. And essentially what that means is it has different effects. It responds to estrogen differently in different tissues. And there are a few SERMs that were already on the market. One is many people have heard of the drug tamoxifen. Tamoxifen is a SERM that is FDA approved for prevention and treatment of breast cancer. So it impacts the breast cell receptor and how it responds to hormones. There's another one on the market called raloxifene, and raloxifene is FDA approved as an osteoporosis drug. So we know that some of the SERMs have beneficial effects on the bone. The one that they studied that's in the DUAV actually is approved both for hot flashes and for bone health.
hmm,
So because we know both tamoxifen and raloxifene is actually FDA approved, not just for bone health, but for prevention of breast cancer. And because we know those were both preventative, they were very interested in saying, well, let's combine with estrogen with a SERM to see if it can prevent breast cancer, treat hot flashes, but will it provide the uterine protection that
right.
progesterone does? And we know that different SERMs affect the uterus differently. So tamoxifen can increase uterine cancer risk.
Hmm.
Raloxifene prevents it. And it turns out this bazodoxifene also is thought to be preventative.
Hmm.
So it's a really interesting drug. It is being looked at currently. There's a trial going on in the US in a number of states that are looking at it in high-risk women, so women who are at high risk for breast cancer, to see if it, who are having symptoms of menopause,
Yep.
to see if it is preventative for preventing, is to see if it's preventative for invasive breast cancer.
It's so interesting. I feel like
Yeah,
it kind of flies under the radar. I feel like we should be
yeah,
hearing about it more.
I totally agree with you. And I don't know if it's marketing, but I feel like it has never gotten a lot of press. It may be because it has been off the market from 20 to 23. And
Yeah.
so hopefully that's going to change because I think it's a really interesting drug. And I think once we see the results of this trial, so it's looking at it for women with breast atypia, ductal carcinoma in situ, family history of breast cancer to see, is it preventative for breast cancer? And I think I actually may have misspoken. I'm not sure if women have to have hot flashes to be in the trial or if they just have to be at high risk for breast cancer. They have to be, it's FDA approved for menopausal women. So they have to be menopausal and at higher risk for breast cancer
Hmm.
to enroll in the trial.
I'm interested to see where that goes. Yeah.
Yep. Yep.
So I want to talk about risk of breast cancer and hormone therapy. the first question I have is, one of the things that you see frequently is that hormone therapy increases mammographic breast density. Do we know that? Is that across the board?
So there are studies that have shown that HRT increases mammographic density. However, one of the things I find interesting is if you do a search on those studies, almost nothing has come out in the past 10 years. They are
Hmm.
all older studies, and older studies mean older types of hormones.
Hmm.
So the answer is yes, there's a thought that HRT increases breast density. I don't know if we know that the most common formulations of HRT that are prescribed today, whether they do indeed increase breast density.
Okay. That's a fair question or a fair answer. And we don't know, but let's talk a bit about what we do know. And I'd like to talk high risk women, those who've not had cancer themselves at this point, and hormone therapy. Do we know who gets a red, who gets a yellow, who gets a green light here? Like what those considerations are? Is it genetic testing? Is it, well, my mom had breast cancer? I mean, what do we know here?
Yeah. So actually, before we go on to that, are you
Hmm?
okay if I go back to the breast density and add one thing on to that?
You bet.
Okay, so one of the questions that people have is why do we even care about breast density?
Hmm.
And breast density itself is a risk factor for breast cancer.
Right.
So breast density is defined on mammography. It's not like you can do a clinical exam and say, ooh, your breasts are lumpy bumpy. That's extremely dense breasts. It's defined on a mammogram, and there are different degrees of density: fatty, scattered density, heterogeneously, and extremely dense. And we know with extremely dense breasts that that's about a twofold higher risk of breast cancer. And with heterogeneously dense breasts, it's about a 1.5-fold higher risk of breast cancer. Now, interestingly, 50% of women have either heterogeneously or extremely dense breasts. What we don't know is if HRT increases breast density, which, like I said, older studies suggest that it does it modify the
Mhm.
risk of breast cancer that breast density does? And
Right.
there have been studies that have had mixed results with that. And again, many of the studies that suggest that it may modify risk are based on studies using older types of hormones than we're using now. So if there's one take home that I would love your listeners to get today, it's that hormones are not hormones are not hormones,
Yeah.
right?
Yeah. That's coming across loud and clear. Uh, so what do we know about um women who do fall into how do we know how do we define that risk, I guess is the first question. And then what does that mean? That population also includes women who have gotten like prophylactic oophorectomies, right? And now we're dropping straight into menopause and really could use some care. It's a big population.
Yeah. So one thing to realize is there's actually no national guidelines regarding the use of hormones in women who are high risk for breast cancer. And high risk is defined as having a family history, having a genetic mutation, having some sort of breast atypia on a biopsy, having carcinoma in situ, or having had breast cancer. Those are all considered high risk. If you've had breast cancer, that's a risk factor for getting another breast cancer. So all of those are considered as high risk. And I think if we're going to talk about like who gets the green light, yellow light, red light, we should break apart and look at each one of those.
Sure.
So first is family history. There have been studies that looked at, can you use hormones when you have a family history of breast cancer and you're already at higher risk? So we know that having a family history, particularly with a first degree relative, puts you at higher risk. And the bulk of the evidence does not suggest that hormones in any way modifies that risk,
Okay.
which means that women with family history of breast cancer can safely use hormones. That doesn't mean that they don't need close follow-up. They still should be getting a clinical breast exam. They should be getting appropriate imaging, whether that imaging is a mammogram or there are people who meet criteria for supplemental imaging with MRIs, but that doesn't mean that they can't use hormones. And a lot of women who are suffering because they get thrown into surgical menopause, they're going to see their providers who are saying, nope, you have a family history, you can't use hormones. So one of the things are, please make sure you're seeing someone who understands the literature and can counsel you. So family history, green light.
Okay.
Genetic mutation. So there are guidelines put out by the National Comprehensive Cancer Network. I am lucky enough to chair their menopause and sexual functioning panels that help put out guidelines for oncologists nationally. And they do it on various aspects of cancer treatment as well as survivorship. And there is no guideline that says people with genetic mutations who put them at higher risk for cancer absolutely cannot do hormones. There's no data. The best data we have is with BRCA mutations, which many people have heard of because we've known about BRCA gene mutations since, gosh, the late 1990s. When you have a BRCA gene mutation, you have about a 70% lifetime risk of breast cancer as opposed to 13% for the average
Yeah.
risk women. And in BRCA1, there's no data that says that the use of hormones will further increase the risk of getting breast cancer. Primarily, there's both BRCA1 and BRCA2, and most of the data is in BRCA1 carriers. Again, those people need special close follow-up if they still have breast tissue. They need alternating mammograms and MRIs, but we do not have good evidence that says they cannot use hormones.
Okay.
So that means a BRCA patient who is at risk for ovarian cancer and gets surgical induced menopause, but still has breast tissue, they can use hormones. So I consider that a green light also. Then you move on to breast atypia. So you've had an abnormal mammogram and you get a biopsy that shows atypical ductal hyperplasia, atypical lobular hyperplasia, even LCIS, lobular carcinoma in situ. We kind of put that in the atypical category. Traditionally, the thought is those women have a much higher risk of getting invasive breast cancer, and you should not give hormones because hormones may influence that risk and increase the likelihood they would get invasive breast cancer. Despite that has been the standard of guidance, we don't have data that shows that for sure. Those are the people that we need to have good studies, and why the DuoV study is really important. I think that they are the people that I sort of look at this as a more of a yellow. It's still, many people would say red light, but it's more of a yellow light. You need to counsel people. It is a nuanced discussion to say the fear is whether hormones could influence the likelihood of developing invasive cancer. We don't have data on that for sure. Standard is certainly not to offer you hormones, but I think if someone is really suffering and they have tried alternatives to hormones, or they understand this is a nuanced area, that with appropriate risk benefit counseling, that they should be offered HRT.
Okay.
Then you get into the DCIS, ductal carcinoma in situ. So that's sort of a little bit, we're moving more on that spectrum towards invasive cancer. And if someone has breast tissue remaining when they get DCIS, so DCIS is a risk factor for getting invasive cancer. DCIS, you can they call it carcinoma in situ, but some people question whether it should even have the word carcinoma in there because you cannot die of it. You can die of breast cancer. You cannot die of DCIS. The cells are all contained.
Very naive question, Press. Is that stage 0 breast cancer?
Yes.
Okay.
Yes. So, but some people question, should you even be calling it cancer at all? The
Right.
problem with DCIS is if it recurs, 50% of the time it recurs as DCIS, and the other 50% is invasive cancer. And we have not done a very good job of predicting who's going to get invasive cancer. Even if you have DCIS in one breast, you are at higher risk for invasive cancer in the other breast. So traditionally, the teaching has been if you have DCIS, you should offer alternatives to hormones and not HRT. Again, this is being studied in DUAV. I think it's not an absolute. I still think that's more of a red light, but there are people that you can, if you do appropriate risk benefit counseling and they understand, that you can offer them that. And again, that's moves it more, somewhere between that yellow red light.
Hmm.
DCIS with bilateral mastectomies. So there is no reason that someone who has DCIS needs to remove both breasts, but there are plenty of people, personal choice, or they decide for some reason that they want to do that. When you do bilateral mastectomies, there are only microscopic amounts of tissue that is remaining, even when they do nipple sparing. And so nipple sparing, skin sparing, there's such a small amount of breast tissue that is remaining that the likelihood of getting invasive breast cancer after bilateral mastectomies in the setting of DCIS is about 1%, that people feel that that risk is so low that HRT is a green light. It's not
Okay.
a yellow light, but even a green light. So DCIS, bilateral mastectomies, green light, DCIS with breast tissue remaining yellow to red.
Gotcha.
And then where's the red light? The red light has still traditionally been if you have hormone receptor positive breast cancer, that large guiding organizations recommend alternatives to hormones. Now, is this being studied about whether we actually can give HRT? It has been studied in the past, and trials showed mixed data. There is more recent literature suggesting maybe we should be questioning that, and maybe we can be offering those people HRT, but I don't think we're there quite yet. I'd like to see maybe we will be in 5 years, but I think right now that's still considered a red light. Gets a little bit more controversial. What if you had hormone positive breast cancer 10 years ago, or 15 or 20 years?
Right.
Well, we know with early stage breast cancer, you can see late recurrences 15 to 20 years down the line. So I think many people in the cancer world would still say, well, that should still be red light. But again, you need to individualize. And if someone is suffering and they understand this is a complex area and literature is changing, then there are patients that I have offered HRT to who had prior history of hormone positive breast cancer. Hormone negative breast cancer. Just as I said, hormones are not hormones are not hormones. Breast cancer is not breast cancer is not breast cancer. Hormone negative breast cancer doesn't mean when someone has hormone positive breast cancer that hormones cause them to get cancer, but it means they will use hormonal therapies as part of the treatment to modify their tumor environment. Hormonal therapies are drugs like tamoxifen, or for postmenopausal women, aromatase inhibitors. With hormone negative cancer, they don't use those therapies. We don't have good evidence that the use of HRT increases the risk of breast cancer in the setting of hormone receptor negative disease. So once someone has been free of disease, was that clear? It looked like,
Yeah, it
was
was.
that?
I'm trying. That was very clear, but I'm trying to put together because I was just remembering. I thought somebody asked a question in our group if you can take hormone therapy if you're on tamoxifen, or if you're, I know that's come up. So when you were talking, I was like, so can those
No, so
coexist?
really interesting question, because, well, let's first finish up
Okay,
with
go ahead.
a green light. Hormone positive disease still generally considered red light.
Yep.
Hormone negative disease, we know when you first have cancer, there's a high risk of recurrence in the first couple years. And so most oncologists will not recommend or allow or suggest someone use HRT in the first 2 years after they've been diagnosed. Because if they do have a recurrence, it's certainly possible they could get a hormone positive disease.
Right.
Once someone has reached 5 years
Yep.
in the setting of hormone receptor negative disease, that's considered cure. You don't use the word cure with hormone positive disease because, as I mentioned, you can see late recurrences even 15 to 20 years later. But with hormone receptor negative disease, if they don't recur at 5 years, they're likely cured. And I have no problems. I put those patients in the green light.
Okay.
There may be some people that disagree and say, well, maybe it should be more yellow, but I think those people with appropriate counseling, we can offer HRT. The 3 to 5 year point, they're still going to be followed by oncologists, and I don't think we should be working in a vacuum. And so, for example, at Midi, our clinicians will reach out to someone's oncologist when they're actively being followed, so we can have a discussion about this is what the literature shows. Your patient is, or our mutual patient is really suffering from symptoms. We want to offer them HRT, and we jointly will discuss this. So that 3 to 5 year point, I think, is still like a little bit controversial, but after 5 years, I will routinely offer women with hormone receptor negative breast cancer HRT.
Okay.
Now, going back to your question about tamoxifen is similar to the drug Induavie,
Right.
right? So the question does come up then, if Duavie is being studied, that's estrogen and a SERM,
Right.
would you give estrogen and tamoxifen?
Right.
Right. So I don't know of any trials that are ongoing. As I mentioned, SERMs affect different tissue differently, depending on the target tissue and the hormonal environment. So tamoxifen happens to be one of the SERMs that does increase uterine cancer risk.
Yep.
So if you were going to be giving HRT to a tamoxifen user, that means if they have a uterus, you have to give estrogen, a type
Right.
of progestin, and tamoxifen. And if we already talked about, if there's a component of hormones that does increase breast risk, it's progestin. And so now you start getting a little bit more complicated.
Right.
I think it's an interesting study about what about in someone who has had a hysterectomy? Could you give them tamoxifen and give them HRT and give them estrogen alone? Again, we don't know. I don't know of a trial that's ongoing, but I think that's an interesting question.
Yeah. No, it's super interesting. Okay, so I'm hearing that there's a lot of yellow to green, and you gave very nuanced answers, and I appreciate that. So for the women who, before I do that, is vaginal estrogen completely safe for everybody as far as this conversation of breast health is concerned?
Uh, the answer in general is yes. I will talk about, there is a little bit of nuance, but let's talk about why you would use vaginal estrogen. So if someone has a vaginal complaint, whether that's dryness, pain with penetrative sex, irritation, frequent UTIs, large guiding organizations in the US say target the tissue of concern with the appropriate drug. Meaning if you're taking a patch of estrogen to help out your hot flashes or sleep difficulties, that may not be sufficient to target your vaginal dryness and painful sex. So you target with vaginal estrogen. You're targeting the tissue of concern. The hormones stay locally with almost no absorption into the bloodstream. There are no studies that have been done that I have seen that show that the use of vaginal estrogen is associated with a higher risk of dying of breast cancer. So in breast cancer users, no studies saying it's associated with a higher risk of dying. In fact, there was a large meta-analysis published 1 year ago, 1.5 years ago, published in JAMA that had looked at that. There was a study that was called the Danish trial, which was an observational trial published in 2022 that found a higher risk of breast cancer recurrence in a subgroup of women, which were women who had hormone-sensitive breast cancer who were on aromatase inhibitors. So aromatase inhibitors are drugs, they are hormonal therapies used to manage postmenopausal breast cancer. They are used in high-risk women, high-risk premenopausal breast cancer. But for them to be an effective breast cancer drug, they have to take those premenopausal women and make them postmenopausal. So the drugs are only effective after menopause. And in that and those drugs work as a cancer drug by shutting down all estrogen production in the body. So there have been questions of, can you use vaginal estrogen for women who are on aromatase inhibitors when they're on a drug that's working as a cancer drug to shut all estrogen down. In this Danish trial, they found a higher risk of recurrence, but there's a lot of questions about it. It was just observational. And we know that women who are on aromatase inhibitors, if they were premenopausal when they started, it means they have higher risk disease.
Right.
They didn't define the estrogens. So there's a lot of questions about that. What large societies say, like the Menopause Society, American College of OBGYN, they basically say vaginal estrogen is safe. If you have someone who's on an aromatase inhibitor, you should have this nuanced discussion with your healthcare provider, which is,
Okay.
again, why I'm constantly saying you need to be seeing someone who understands literature. Literature is changing all the time. You know, what we knew back when the WHI came out in 2002 is very different than what we know of in 2024. And
Yeah.
you need to see someone who is educated in this area, keeping up with the literature so that you can help make an educated decision as to what's right for you.
Yeah, totally. Thank you for that. So for the handful of cases that you've talked about that, it is a more of a red light, if not completely off the table. What are some of the best options for these women? Do we know anything about fezolinetant at this point, Veoza, as far as, these for a truly high risk population?
Um, yes, we do. And I will answer the question first by saying one of the things I always say in any talk I do is just because you have breast cancer, do not let anyone tell you that you need to suffer from symptoms. There
Fair.
are always things that can be done.
Yep.
And there are many treatment options. And to put a little plug in for our survivorship panel on the NCCN, we have guidelines for oncologists throughout this country and other providers with ask questions. If someone says they have symptoms, here's a whole list of treatment options with doses and information about that. So there's a whole host of alternatives to hormones that have been studied over the years for treating, these are primarily for treating vasomotor symptoms, so
Yep.
hot flashes and night sweats. There are studies that have looked at low doses of antidepressants, neuropathic pain medicines, anti-seizure medicines, overactive bladder medicines. And many randomized control trials, oftentimes short, but there's randomized control trial data that showed a benefit for these drugs. Before fezolinetant came out, we would say these drugs are sort of interesting. We don't know why they help with hot flashes. We know that they cross the blood-brain barrier, and we know that there's some temperature control regulation or mechanism within the brain, but we don't exactly know how they improve hot flashes. And interesting, for many of those drugs, they were used in lower doses than what the drugs typically intended for. So
Mm.
some of the antidepressants, like one of the most common ones used is a drug venlafaxine. The trade name is Effexor. And they use as high as 375 milligrams for treating depression, yet the most effective dose for hot flashes is 75 milligrams. So they were sort of interesting. They studied different doses of all these diverse drugs. Fezolinetant is the first drug that we understand how it impacts hot flashes. So it impacts the area of the brain in what's called the KNDy neurons. And these KNDy neurons are influenced by estrogen withdrawal. And so this drug targets specifically that area within the hypothalamus that is where hot flashes occur. I think it's the first drug of probably many that are in the pipeline,
Yeah.
but I think it is, and it is FDA approved.
Yep.
So it is an FDA approved alternative. It got FDA approval. It's only been a year now. So we don't have lots and lots of follow-up. I have seen it seems to be successful, seems to help out with sleep. I would love to see longer data to really see how effective is it. Will it help out with other symptoms that we see of menopause? But I think to have another tool in the toolbox for breast cancer survivors is
Yeah.
awesome. We need a heck of a lot more of them, but the big take home is no one should feel they have to suffer just because they have breast cancer, even if they're told that HRT is a red light.
I think that's a perfect place to put a bow on this conversation. Is there anything that you wanted to make sure that we heard or talked about that we haven't covered in our conversation?
I think we covered this pretty well, but I'm hoping that people hear that estrogen does not cause cancer. And if anything, the best data we have now suggests that estrogen prevents breast cancer and is associated with a lower risk of dying of breast cancer. I also want people to really hear that we know a lot more about hormones now than we did 20 years ago. Hormones are not hormones are not hormones. We use safer formulations, bioidentical formulations, similar to what our body produces, that I think for the vast majority of people are safer, certainly lower clot risks. We didn't talk about the benefits of hormones in terms of other diseases, other than sort of what the WHI follow-up has shown. But we know that HRT is the most effective treatment for symptoms and the whole host of 50 or odd, symptoms that people can experience in the perimenopause and menopause. But HRT, if started at the appropriate time in life, prevents heart disease, prevents bone loss, increasing data that suggests it can prevent cognitive loss. So there are so many reasons that when people are in the perimenopause and menopause time of their life, they should realize, A, I shouldn't suffer, and I should at least have an educated discussion with someone who understands menopausal medicine and understands the risks and the true risks and benefits of hormones to see, is this a right option for me? And if it's not, and I'm in that red light group, I should be able to get treatment options as well. No one should have to suffer at this point in life.
Well, that's our show. Come on back next week when I sit down with a few members of our Navigate Menopause cohorts to give us some insights on what they've learned, what they're doing, and how it's making a difference in their menopause journey. So come on back for that one. And until then, as always, stay feisty. You've been listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I'm your host, Celine Yeager. The show is edited and produced by the strong, talented, and amazing women at Live Feisty Media. Follow us on social media at Feisty Menopause, and please help us spread the word. Screenshot and share this episode on your social media channels with the tag @FeistyMenopause. Share the show with your friends, and please subscribe, like, review, and rate this show wherever you get your podcasts. Word of mouth and good reviews make it easier for other listeners to find. Thanks for listening, and as always, stay feisty.